Dr. Ranjan that in 1996 we met in American Academy of Neurology. Trial had come out and it was exciting times, and the most excited person was Dr. Ranjan himself because he was establishing stroke services in Apollo, Delhi, and he was full of talking about all that, and it was not licensed at that time. In India, of course, not even in US. I'm talking of 1996, early 1996. But as you can see, it's 14 December 1995. It was a very important issue because TPA was for the first time published here, and low molecular weight heparin, which also happens to be a stroke treatment, at least for DVT prophylaxis. And the editorial was acute stroke on the threshold of therapy. And since then, everybody of us has been excited about TPA. Then why this rethinking? So once Dr. Ranjan told me that you have to talk on this rethinking, so I looked into website and I looked into Google, and I found that there is a very important lobby which is talking against TPA. And many of them are from the field of emergency medicine. Look at this. Thrombolysis in acute ischemic stroke, time for a rethink. And they are questioning the evidence in favor of the TPA. And this was 2009. But as recent as 2018, there's a Viewpoint article, IV TPA is still a naked emperor. It's an emperor, but it's naked, without clothes. Why do they think so? Well, they think it has status, but it's not effective. At least usually it's not effective. And when we say that miracles happen in TPA, we have seen TPA patients getting TPA and walking. They said these are only in the minds of neurologists. These are anecdotes. But when you look at the data doesn't capture these miracles. In data, the evidence is only modest. And once again, I am not telling this. This is one lobby, particularly of emergency physicians. Their first question is that stroke trials are not as powered as MI trials. Our numbers in our trials are not that big. For myocardial infarction, 14 trials of more than 140,000 patients proved that lytic therapy improved outcomes. Whereas a 2014 Cochrane review of 27 stroke trials included only 11,000 patients. So our stroke trials are not as powered, so to say, as the MI trials. Number one. Then 10 randomized clinical trials assessed functional capacity in patients with acute ischemic stroke, out of which 2 were streptokinase and 2 TPA trials. They were stopped because of harm or futility prematurely. 4 trials were equivocal, they were neutral. That leaves only 2 positive trials. One is NINDS and one is ECAS3. And if you see, frankly, these are the 2 trials based on which we are. Now, what they claim is that if you take any ineffective treatment, and if you take 10 trials, by chance alone, 2 of them will be outliers, and they will look like to be positive, you know. And the other thing they are saying, because they have really spent nights in sifting this data and looking at each and every column and all, when the NINDS trial came first, they showed us that the TPA group and the placebo group were balanced. For any clinical trial, you know, you have to have balanced groups in the beginning. But they say that later on, after 10 years of the NINDS data, when it was again published, they found that there was a sub-analysis found that there was some discrepancy. They were not completely balanced, which means that in the TPA group, those patients were generally, at the baseline, they were a little better compared to the group which was in the placebo. So therefore, TPA got an advantage. So at that time, a lot of criticism. If you today also go into Google, you will find there is a lot of discussion going on about all these issues. And then they said that in the TPA group, the mortality was more in the first few months. After that, it got balanced. But if you see in the first 3 weeks or first 1 month, mortality was more in the TPA group. That was the other objection. And as far as the ECAS3 is concerned, they say that they are again not completely balanced. The TPA group is little favorable baseline compared to the non-TPA group. And then in the as far as the benefit or the outcome is concerned, it depends on how you measure the outcome. In the ECAS-3, the good outcome was measured as 0 to 1. Now, if you say, what is MRS-1? 0 means normal. MRS-1 means that he is normal, but he has got minimal thing. But MRS-2 also is almost same. That he can do his usual activity, does not need help, but it is little different than before. So they think between 1 and 2, there can be a lot of inter-observer variability, lot of subjective variability. So if you change the outcome from 1 to 2, then the difference is not that significant. But if you keep it 1, it is significant. They are questioning that also. So they are questioning NIDS, they are questioning ECAS. So therefore they are saying, even though you are seeing miracles in your case-based analysis, but if you look at the whole data, it's not that impressive. This is what is said by the emergency physician who think it's a time to rethink. And then finally, I wish Dr. Kameshwar Prasad was here. They think final blow was the IST trial, because IST trial was not such a huge success. Even though it showed that patients more than 80 years can be given TPA safely, yet it did not come in guidelines at that time, right? And then, of course, everybody accepts that even if you get a small benefit by giving TPA, there's also an increased risk of hemorrhage. You do that bargain. You take the bargain of ICH at the cost of some benefit. So based on that, they think that we should again rethink, but they also accept that it is difficult to rethink this because it has become so much entrenched and established that nobody will do this, nobody will take this risk of reversing the whole thing. But at the same time, if you look into the Google and all, there's these counter arguments about the efficacy, and this questioning about TPA is happening all the time, mainly driven by the ER lobby. In fact, 2 years back, there was a big editorial and discussion in the New York Times, and there were also interviews on the American radios and all, whether it's worth it. But most of the stream is in favor of TPA, except this small lobby of ER physicians who are questioning it and asking to rethink. And the worst is hitting below the belt. They think that the approval of TPA was premature, disregard to the norms of the FDA. Normally you need 2 independent trials showing significant benefit, but here it was done based on only 1 trial. Second, they think that many of the FDA committee members who actually approved it, they had conflicts of interest in this, because many of them had some interests in the TPA Genentech company at that time. Genentech had also funded the AHA building in the USA. And some people who wanted to talk against TPA, they were taken off the board. So a lot of controversy was created. After I saw all this data, I thought that this was a pessimistic way of looking at things. If you look at a glass, you can always say this glass is half empty, but you can always say this glass is half full. So now I will tell you the other side of the picture. That was the negative side. The positive side, at least because I have been thrombolizing for the last 25 years like all of you, should we wait till we have an ideal drug which does not cause any hemorrhage? It's not possible. Even in cardiology, hemorrhages happen. After streptokinase, hemorrhages happen. Should we wait till the recanalization is more than 95% or 100%? And should we deny total recovery to those patients who respond to it? Even if they are 13 out of 100 or 30 out of 100, if they become totally independent, should we deny it and wait till we get that ideal drug which doesn't exist? Ideal drug doesn't exist. Even aspirin is not ideal. Even clopidogrel is not. So therefore, I really don't agree with the criticism that we should wait and we should rethink and all. I think if at all we should rethink in a positive way. This is the NINDS trial. And there is a clear-cut increase in the benefit of 55% in the NIHS score. There's a clear-cut 33% relative increase in the independent outcome. If you take MRS, there's a 48% relative increase all across the board in all these scales. There's a benefit. Of course, it's not 100%. It's not 100%, but there is a statistically significant benefit in the group which is getting the TPA. There is no doubt that from the very beginning it has been said that the RTA effects are time dependent. From the initial, we know that it is the best results were found if you give TPA within first 1 hour. There's a 3 times chance of improvement becoming independent at 3 months if you give it within first 1.5 hours. But as the time goes, that becomes less. After 3 hours, it's only 1.64. After 3.5 hours, it's 1.3 odds ratio. So time is brain in this situation. So that has been very much transparent right from the beginning. So if a patient at 4 hours gets TPA and does not respond, I don't think that that is any surprise to us. That's very well known. Time is brain. The earlier, the better it is. Speed is the essence. And in fact, now, after 4.5 hours, the recent trend is to go to 9 hours. But up to 4.5 hours, you don't have to do any fancy imaging. But if you want to give it 9 hours, you have to look at the diffusion, at least the diffusion. And if possible, perfusion also, and you can go ahead.